All right. It was great to hear all the discussion going on. I hate to break up the parties that you all are having. And I hope things worked out okay online, and online folks were able to connect with at least one person they hadn't had the chance to meet or talk to before, and ditto in person. So what we're going to do with all the wonderful material that you generated is that we will collect it all, and we will compile it and share it back out with all of the attendees of the summit. So you have that for reference. Okay, it is now my great pleasure to introduce your next moderator, Cresten Mansfeldt. Dr. Mansfeldt is an assistant professor at the University of Colorado Boulder in the Civil, Environmental, and Architectural Engineering Department and Environmental Engineering Program. And your speaker's there. Excellent. He leads the Creative Microbial Biomaintenance for Greener Environments in Municipalities, CMBM GEM, love it, research group with active projects in tracing the fingerprint of the built environment biome in natural waters, tracing biomarkers of hazard exposure and disease, and predicting the ecological risk associated with new synthetic microorganisms. Overall, his work combines molecular characterization, machine learning, and reactor development to better understand and ethically collaborate with our built microbiome. All right, take it away.
Well, thank you so much. And also thank you for that introduction. It is really my pleasure to be here and also be in 3 dimensions, because I will mention that I have known the first speaker via 2-dimensional Zoom for probably the past 3.5 years and have really respected the work. But it's nice to actually, it's like, oh, you are really a human. So this is great. So it is my pleasure to be able to introduce the first speaker in this session that is really covering much more the ethics, the legal aspects, and the social aspects. And I really like this role of being just the moderator because I'm the guy that just asks questions. I'm an environmental engineer, and I had the privilege to both turn on and off a campaign. And in that kind of role, I then started to ask the questions like, hey, what are we doing? What did we do? And did we do it great? And how do we actually communicate this outwards? And so this is somebody who's been doing this role much more professionally and in much more audience and on the ground. So the first speaker of this session is Wydale Holmes. She's the director of the Strategic Management and Innovation Office for the city of Tempe, Arizona. And she oversees Tempe's Wastewater Bio-Intel program. Also another great name. I just love Bio-Intel. An innovation to change the trajectory of community health at a local level with science, equity, and trust. She leads the Strategic Management and Innovation Office to advance a city culture of innovation and sustain the focus of the City Council priorities and the city's strategic plan. The office operationalizes innovation, manages change, and collaborates with City Council, community stakeholders, and city departments to advance organizational initiatives and a data-informed culture. Ms. Holmes is a certified public manager with a master's degree in public administration, and I really look forward to your talk.
Well, thank you. Good afternoon, and thanks for having Tempe, Arizona on the schedule today. I'm just really proud to represent the people back in Arizona in a very dry, not humid location like it is here today. And everybody from our municipal team to our data scientists, to our Tempe Fire Medical Rescue, to our collaborators and researchers at ASU, TGen, Murray State in Kentucky, as well as to our state, county, and local health departments. I'm just really pleased to represent all the work that this team has done over the last few years. So as Cresten said, we really are trying to use innovation, this emerging science, to change the trajectory of public health. And we started this journey back in 2017. And at that time, I wanted to just share that we have a distinguished person in our audience today, Dr. Adam Gushgari. He was actually a PhD student when I first met him, and kind of threw us into this realm of wastewater surveillance. So thank you, Adam. It was good to see you today. Let's see. So a little bit about our journey. I want to share a little bit about our operations. And the reason I want to share operations is because that really relates to the ethics of how we approach wastewater in Tempe, Arizona. Trying to get this to move along with me here so I can see what screen I'm on. So first of all, we have a shared purpose with our community. Back in 2017, about 2% of our fire EMS calls were related to opioids. And we knew this because our firefighters were trained on how to collect that data. And they also were trained on how to look at the environment in which they're responding. So we know it's probable. We also were looking at fatalities as well as other challenges in our communities. But opioids, 2% of our calls, that translates to about 12 calls a week with a possible fatality. And when we ask about why are we doing this, I look at if we had 12 fatal car crashes in our city, we would do something different. And we would put innovation out there to try to figure out how do we prevent this from happening. And so that's why I'm really a proponent of wastewater. I'm not an epidemiologist. I'm not a PhD. I'm just a local government geek. And I just really wanted to find different ways to help our community. So when we started this journey, it was because we had a shared purpose with our community of stopping this opioid epidemic in our city. Before we launched our wastewater dashboard, we had an opioid town hall. And we were able to launch a dashboard at that town hall because we had a community conversation to destigmatize, to also share that it is prevalent in every area of our community, not just those people, that place over there. ASU Biodesign Center, Dr. Gushgari and his mentor, Dr. Ralph Halden, came to Tempe and they said, hey, we've been looking at wastewater internationally. What do you guys think about doing something? I said, well, how does it relate to an opioid epidemic that we have? Went before City Council, and one of the very contentious questions that was asked at that presentation was, what about the ethics of this? And so without the researchers and scientists and the medical community supporting this, we probably would have not gotten anywhere. But we were able to answer those questions on how do we mitigate in regards to having equity in this program? How do we mitigate the concern for privacy? So I'd like to just share some of those ideas and practices that we have today. So we had the opioid town hall, launched the first wastewater dashboard related to 7 opioid analytes. Because the dashboard was a communication tool and engagement tool, we wanted to make sure that every member of our community could access it. So it's on our tempe.gov wastewater site. It's in multiple languages. I stopped counting it over like 180 languages. We're a very diverse community. We're home to Arizona State University, one of the largest universities in the United States. So we knew that not only putting this program in context was important, because then people could connect with it a little bit better. One of the best anecdotes that was shared with me that I continue to share every time I speak about this is I asked somebody, hey, do you ever go to your doctor and give blood tests and some of that other stuff that they want for analysis? And they're like, yeah, sure do. I said, we're just doing this for a community. We want to make sure our community is healthy. And so with the dashboard, we publish our data, we publish our graphs. We also share what we don't know, as well as illustrations that will help people understand how does wastewater epidemiology work? And then most importantly to us as a city, what are we doing with that data? How does it inform our policies, our decisions, and our strategies? We were also able during the pandemic to pivot in March 2020 to analyzing for COVID. And that helped us really focus on some areas around the city that were most vulnerable, that needed access to, even at that time, very limited resources. And so we've talked about in a couple of our breakout groups about data utility and the ethics and the engagement of our stakeholders. So privacy is the first question I usually get. And so we've established a threshold of a population of 3,000. You'll notice on our map here in 2020 or 2018, when we started, we had 5 collection areas. City of Tempe is about 40.2 square miles. We cover the entire city. Your wastewater engineer is your best friend when you're establishing these programs. We work with a pre-war system. When we had 5 collection areas, we said, okay, that's great. But the pandemic hits. We're able to start analyzing for COVID. And it's like, wait a second, we've got some very large areas. How can we focus our resources and our practices and our operations in areas with greater need? And so we broke it down into about 7 areas. And now by the end of this year, we'll have 11 collection zones. We actually collect upstream. I know that's not popular, but that's what we do because we know that the closest to the distribution or the provider of the source, the better the data is. We have extreme temperatures in Arizona. We know that the integrity of the sample can be maintained. And so this is basically how our program works. We collect over, about 22 samples a week. And then we report the weekly averages on the following Monday, or actually the next following Monday, so about 10 days later. And we work with very different labs across the United States. One of the things that I'd also like to share is that the dashboards, they need to be understandable because I'm not a doctor, I'm not in public health. I help support public health across the city, but I needed to be able to understand it myself. So are the dashboards, and really the story is most important. Are they easy to understand by your community? That makes it accessible to everybody. And then also, don't just rely on people to come to your dashboard. Take your dashboard and your story to them. We have a mantra that we meet people where they are. And if they're hesitant to vaccinate, we're going to meet them there. If they feel like they're more trusted in a school environment or a church environment, we're going to meet them there. And so literally during the pandemic, and the same with opioids, we met our community where they were in the state of being. So we have the other piece that's important to us as well is the emergence of other biomarkers. We specifically don't use the word target or surveillance. Not that it's not that, it's just it doesn't connect well with our community. And so we let them know, hey, we're looking at biomarkers. These are just indicators of health for our community. And just having that common language and the consistency of the language has really helped with us. We're getting ready to launch another part of our dashboard on October 20th with other infectious and respiratory diseases. And we also were able to start sharing with our fire department and our community in regards to xylazine. And while we haven't had a detect yet, it doesn't mean it's not there. And we're very used to telling that story. It just means we don't have the right fishing lure, if you will. So mainly, I would just encourage you to meet your community where they are. That also means meeting where your other stakeholders are, whether it's where your researchers, where is your health department in this, and as well as your elected officials. Those are very important funding mechanisms. When we were building out our infrastructure, we felt that it was important to think towards the future. So our city council invested about $1.5 million in our infrastructure. So now we have dog houses. Instead of sending our team into manholes, we have these dog houses where we have 24-hour composite samplers. We knew that the health and safety of our community members as well as our employee teams was very important. The other piece is combining this with other data. So we don't utilize wastewater data alone. And I get a lot of questions in regards to law enforcement. And Tempe is getting ready to step into that space, but we're not utilizing wastewater alone. We're utilizing, just as we had during the pandemic, other data sources, our calls for service, our case data, our fatality data, other items that can help inform us as we move through unfortunately, our continued opioids journey. So one of the other items in regards to the ethics of these programs is we follow our open data policy. This policy was drafted alongside our wastewater surveillance program, as well as alongside other data sets that we collect as a city. So it wasn't done in isolation just with wastewater surveillance. Let's see here. The other thing, we publish other data that can inform our community. So again, it's not just wastewater data that helps us learn where we're at as far as the health in our community, such as our opioid medical service calls. We also published in regards to the pandemic, our vaccination rates, our case data. When all of that wasn't available, people looked towards wastewater. We had a neighboring community, the town of Guadalupe, who is the Yaqui Pascua tribe. And we said, hey, we'll take your samples. We run your water system anyway. We'll take your samples, we'll have them analyzed, we'll put it on our dashboard. Their town was in disbelief about COVID. They wanted to have Mother's Day celebrations, very large Easter celebrations. And when the data was released on the town mayor, as well as their council members, were able to go to the community and share, this is what's happening, this is real. So it kind of helped create that kind of a pushback against denial, if you will. But one thing that's really important about this is also sharing the utility. How do we utilize this data? So for example, our fire department, They now stock more Narcan on their paramedic trucks because they know that we have an uptick in the signal across the whole city. They also knew that we could do contactless door-to-door campaign during the pandemic in areas that were still showing high levels of COVID in the wastewater signal. So we're able to adapt based on some of this data. It's not the whole story, it's just one piece of the story. Again, this is an interdisciplinary approach. Wastewater doesn't tell the whole story. It tells a lot of the story. And as one of those town council members over the town of Guadalupe said, poop doesn't lie. And so we let people know that this is the consistent piece of information because we're pulling back on case data. People aren't testing at their doctor's office, they're home testing. So we do have some data voids that this can help address. And the other thing is to make sure it's actionable. And so we created different methods of public engagement, whether it's through our town hall, to our door-to-door contactless information, to constantly having this as a presence. Every year, about 4 times a year, I give an update to council, as well as to other community groups. Our mayor's state of the city addresses this, our neighborhood state of the city addresses our wastewater program, and as well as having our ambassadors of our employees and our scientists that we work with in regards to the program also telling the story. So I'm watching the clock here, Cresten, because I know you said you went to Germany and you're very efficient. So I've got about a minute. So it would be remiss of me again not to remind you that this work can be done. Sometimes sharing what we don't know is just as important as sharing what we do know and trusting your community. When we talk about open data, it's not because people are reticent sometimes because they think, well, people will misinterpret it. Well, without having other data, you're not going to be able to tell that story either. So I know that it takes courageous leadership at all levels of wastewater work, whether it's our operators who are in the field day in, day out, collecting our samples, to our scientists that are being courageous in their discoveries and sharing what they did learn or what they didn't learn, to our health department collaborating with us in regards to what do we do if our signal hits a certain level or it falls below a different level. So trying to create the pathway. You all are trailblazers. And another mantra besides meeting people where they are is it's hard to be first, and you're the first. You're the first generation to really take this work worldwide. And so I would just encourage you to continue on. There will be obstacles, but you can get around them. And I think the collaboration, the networking that you have with groups like this, again, is the way to go to it. So again, I just wanted for you to be able to know who our partners are. CDC, first time we ever talked to Amy Kirby, her dog was running around in the background, my dog's running around in the background, and we were talking about what about the what ifs. Our Maricopa County, our Department of Health from the state, ASU Biodesign Institute, TGen, the National Association of City, Counties, and Health Organizations, huge partner. They helped us mentor 2 counties in New York, but we've also been able, most importantly, to develop that relationship. And we know not all of this is going to happen because the bureaucracy works perfect. It's going to happen because of the relationships that you build. And then also I would give a shout out to our colleagues at Murray State who test our wastewater for xylazine and that emerging pathogen, if you will. So with that, just thank you again, and thank you for being the trailblazers, and appreciate your bearing with me of the slides. And then also I just want to share that it's an interdisciplinary approach. I've heard about utilities, I've heard about our researchers, but it takes legal, it takes our fire medical rescue, it takes our wonderful GIS people who can help map our collection areas. And so I just really want to encourage you to bring more people into the conversation and into the planning of your program. So thank you.
Thank you so much. Thank you for being adaptable midstream of the talk on the technology, but thank you for the story and the presentation of how you're incorporating all of the data within the realms of community service. Moving on within kind of this discussion of some more of how the data has social implications, we have, sorry, I was just leaning over there. We have a speaker now who will be talking more on the legal considerations for wastewater surveillance. So we have Govind Persad. And Dr. Persad is a Juris Doctorate and a doctorate in philosophy. Is an associate professor at the University of Denver Storm College of Law. His research applies bioethical and distributive justice frameworks to law in order to address longstanding and new problems at the interface of health law and policy. These include drug pricing and the allocation of scarce medical resources. His recent writing appears in law reviews such as the Iowa Law Review, William and Mary Law Review, and Emory Law Journal, as well as medical and scientific journals, including the New England Journal of Medicine, Science, JAMA, and the Lancet. So thank you all, and he'll be presenting online.
Great, thanks everyone, and I'm really excited to be here. My title and content will be a little bit different, I think, from what Cresten was mentioning, in that I'll probably end up talking more about ethics and a little bit less about legal implications, but I'm happy to talk about law as well in the Q&A, if that would be useful. So this talk is titled Ethics and the Public Display of Wastewater Pathogen Data. And are you all able to see the slides? I have, Anna said that she sees the presenter, not presentation view, but I'm hoping that it's showing up now. This project first was organized around trying to identify some different values that we called both substantive and procedural values, with the specific focus being issues around the ethics of display of wastewater data. And so our focus was much more on issues around public display than around the more general question that many of you are working on of ethical issues related to the collection of wastewater or wastewater monitoring. And drawing on work in other public health domains, we identified four what we thought were core substantive ethical values that were important to thinking about when and how it was appropriate to display wastewater data to the public. And these values include first what we call benefiting people and preventing harm. So the idea that having wastewater information displayed to the public could help the public in terms of having the ability to protect themselves against harm from pathogens, and could enhance the benefit of public health efforts. And our focus in particular on public display issues was around infectious disease pathogens. So I think the issues around opioids, which was not as much our focus for this project, are really interesting and are worth thinking about when we get to the framework section next. So the next value we identified we call mitigating unfair disadvantage. We can think of this as sort of a health equity focused value. It's particularly concerned with not only benefiting people, but trying to ensure that people who have previously been unfairly disadvantaged are prioritized when thinking about the benefits of these policies. Third substantive value is privacy, the importance of being protected against disclosures of information that would violate privacy, and then autonomy. So one reason to publicly display data can be that it allows individuals or communities to make decisions about managing risk for themselves more effectively. So beyond being able to benefit these communities or protect them from harm, it also allows them to decide more autonomously. We then also identified a procedural ethical value, which we call good governance, which is that decisions about public display of data should both be responsive to public values, and the reasoning about decisions should be transparent. And then public display of data could itself serve to have a sort of positive feedback loop to enhance good governance by making it possible for the public to make and be involved in decision making in a way that is more responsive to information. In terms of setting up our framework, we identified several different factors to consider when making decisions about whether and how to display data about pathogens. So the ones in green were ones we thought make the case stronger for public display, which include the condition being caused being a severe condition. The second one we thought can sometimes count against public display of data or recommend at least being very thoughtful in how that display is tailored, which is if the condition at issue is one that is stigmatized among the public, that can have implications for thinking about public display. Another consideration is whether data about the prevalence of a pathogen will help the public reach accurate conclusions about the risks, say, that they're exposed to from that pathogen. Another one is whether the condition is communicable. So as I mentioned, we're focusing more on infectious pathogens. If a condition is communicable, that may strengthen the case for the public being aware and data being displayed to them about pathogen prevalence. Last is, can action be taken to avoid the condition? So to the extent that it would enhance public autonomy and would help to benefit people and prevent harm to share this data, that will be more true when the public could take action in response to avoid exposure to the conditions. You saw this discussed with, for instance, COVID-19 wastewater surveillance. So once we have this framework on the table, it's worth thinking about how to apply it to a few different types of pathogens. And we don't have this in the current draft, but it'd be interesting to think about how to apply it, for instance, to data around the prevalence of opioid traces. So the example of xylazine, I think, would be really interesting to think about in this framework. So say you had wastewater data on a condition like flu, or like COVID to some extent. Flu is not really a stigmatized condition. It is certainly communicable. So being in a location where there's a lot of spread, you would be at higher risk. Data could help avoid for conditions like flu and COVID in various ways. There are individual level precautions people could take. So it could lead people to get vaccinated. It could lead people to seek to do activities outdoors, things like that. And then also, let's say flu falls into the category maybe of moderate severity, where it can be very severe for some specific groups, but it's not at the level of severity where it's a condition with, say, a very high case fatality rate. So in general, we thought a lot of the considerations point toward sharing that type of data. We had a couple other examples. We're thinking about which ones to include, this being a short draft. What about a condition like dengue or one like syphilis where it is more stigmatized? And so having this data, if it's possible to collect that wastewater information, might raise more questions about stigma. So I think it'd be really interesting to consider how to apply that framework to these contexts. In terms of legal issues, here, for those of you who are disappointed by the talk being a little different from the way it was pitched, some areas that we've been exploring are whether displaying de-identified wastewater data can still violate any sort of state or local privacy laws or anti-discrimination laws. And then some questions about whether public display of data could ever really lead to any risk of re-identification and what legal risks those will present. Last one is just not exactly a legal risk of surveillance, but sort of a risk of not publicly displaying data, is that if you have data that you're collecting but not publicly displaying, to what extent is not publicly displaying the data actually risky, because data could end up being revealed in ways that are less understandable, easier to cast as scary or to misrepresent if that data ends up being revealed via FOIA or via leaks, not say at an identified level, but at the level of community level data. So we thought that was an interesting legal dimension. Then last, we were interested in issues around implementation. So I think one important issue for displaying wastewater data that's already been touched on is the accessibility of it to a broad swath of the public. Some considerations for us that we've been thinking about are people who may not speak English as their dominant language, people with, say, visual disabilities, and also the general area of technological comfort. Also have to some extent the challenge that some people may remain outside of sewer sheds. So say some people who are unhoused may not be as connected to sewer sheds as people who are regularly using facilities that connect up to a wastewater stream. Privacy risks I mentioned from identification, sort of balancing that against having more granular data. And then the question of whether to present data in different ways to the public compared to experts, whether there's some data formats or ways of data presentation that might not be useful to the public, but would be more useful to experts analyzing that data. So how to think about multiple stakeholders when involved in presentation. And this project grows out of some work that I've been doing for the Colorado National Wastewater Surveillance System Center of Excellence project. Doesn't represent their views at this point. It's certainly in the draft. It's my views, and also the views in progress developing. I won't speak for them, but of the collaborators who've been working with us on this project. So Anne Barnhill at Johns Hopkins, Nathan Lacrosse, who's here, I think, in this Zoom audience, Renee Landers at Suffolk University, Doug McKay at UNC, Natalie Ram, who's a major legal thinker in this area, who's at the University of Maryland, and Robert Steele, who's in the bioethics department at the NIH. So I'll actually just go ahead and stop here at this stage in the project, or talk is pretty short, but I'm very excited to hear all of your questions in the Q&A.
Thank you so much. And yes, we'll have time for Q&A at the end, but we'll move right along here. So up next, we have Dan Lang. Mr. Lang is the Deputy Director of the Center for Environmental Health in the New York State Department of Health, and has worked in other leadership roles since joining in June 2017. He is a New York State professional geologist and has 30 years of experience in the environmental field, having worked as an environmental consultant for 25 years after receiving his master's degree in hydrogeology from Rensselaer Polytech Institute and a bachelor's degree in environmental science from the University of Rochester. And he'll be speaking today on the ethical considerations related to poliovirus testing in wastewater.
So yes, thank you, and for the invitation to be able to talk to you all today about our rapid response. There we go. Hello. Rapid response outbreak investigation last summer in 2022 from our unwelcomed guest, the polio virus in New York State. So this case was not identified by wastewater. I'll try to point that out right away. We were not monitoring for poliovirus in wastewater at the time. But through some acute flaccid myelitis enhanced surveillance that was going on in New York at the time, an astute doctor who had a case of or a young adult that came in from some paralysis, was tested for and confirmed to have vaccine-derived poliovirus as a type 2. And what that indicated to us and the CDC at the time was that this was most likely not an isolated case, and that there could be a asymptomatic transmission of poliovirus in the downstate areas. This happened in Rockland County, which is a county outside of New York City. So I guess the first, ethical consideration that I wanted to bring up here is, we had already a very robust, expansive network of wastewater surveillance going on for SARS-CoV-2 in New York State at the time. So we are now over 200 locations throughout the state. At that time, I think we were upwards of 120 or 130 sites, many in the downstate area where the polio virus was detected. So we capitalized on that and began to collect additional nucleic acids from samples that had been, or that were already being sent into the lab for SARS-CoV-2. So I guess that's the first ethical consideration, is that in the event of an outbreak or a case of an emerging or re-emerging disease, is it okay or appropriate to to add pathogens to your existing network? Given this particular pathogen that can create paralysis and affect, especially unvaccinated people, and that the fact that it's asymptomatic spread made wastewater surveillance an appropriate tool to be able to understand the scope of the outbreak. At least that's the decision that was made at that time. So at the time, we had already had 28 sites that were collecting samples for SARS-CoV-2. And that's before July 21st. That was the date of when the case was identified. And so that we quickly ramped up additional testing. So in addition to the 28 sites, we added almost double the amount of sites. And we also were able to use archived genetic material to go back in time, all the way back to March of 2022, to be able to understand when poliovirus was first detected in New York. And it turns out that it was present earlier than July, dated back to samples in April and May in Rockland County and some surrounding counties. So I guess that's the next ethical consideration, is, in the event of an emerging pathogen or something like that, is it appropriate to use genetic material that had been archived to test? And is it appropriate to add additional sites that weren't intended for analyzing for a polio outbreak? And again, since polio has been, or poliovirus has been tested in many other countries and in this country in the past, in wastewater to identify areas of potential polio transmission, we felt that it was appropriate to be able to expand the network and also go upstream. And so this is one of the other considerations that everybody has been talking about, is it appropriate to go upstream and identify smaller areas within your sewer shed, to be either able to understand better what the transmission dynamics look like, or to identify where actions could be taken. In this case, the sewer shed that in Rockland County that had the largest or had the polio virus detection in wastewater was also one of the largest ones. It represented about 140,000 people in that county. And so, together with CDC and the local health department and the state health department, sites were identified upstream of that treatment plant to be able to identify other areas, or at least try to get a sense of, is this coming from one place in the county, or is this coming from multiple places within the county and outside the county? It turned out that the upstream sampling did not reveal that there was only one or two locations in the county. It verified that there were multiple locations in the county, and we also identified poliovirus in neighboring counties, which gave us the NCDC the information needed to understand that this was not a isolated case, that this was widespread type 2 vaccine-derived poliovirus transmission in the downstate area. So we continued to do, additional sampling in the upstream locations as well as the neighboring counties throughout the fall. And as this heat map kind of shows, is that poliovirus detection waned in the latter part of the year. So around late September, October, the detections of poliovirus in wastewater diminished. We have continued sampling in all of the counties. We've got rid of some of the upstream sampling locations for the time being, just because it's more resource intensive. But we did continue that, and throughout this entire summer, we've been posting weekly updates on our website. And to date, we have not detected poliovirus in any of these locations this year. So that's a positive thing, that we did not have a repeat of last year. So part of the other ethical considerations is how is the data analyzed and what information is shared with the public. And so from the very beginning of the work that we did on this outbreak, we, together with CDC, got information out rapidly on poliovirus detections. We did so through two MMWRs, as well as generating a weekly report that was posted on our website every week with updates as to what locations were tested, where poliovirus was detected or not detected, and then with maps showing locations of the sort. And as I mentioned, we continue doing poliovirus surveillance in the area. We also have done a retrospective test for poliovirus in other parts of the state, which that report isn't out yet, but we'll be getting that done in the next few weeks, maybe probably a couple months, when that all comes out. So again, an unwanted guest in our state last year, but we responded rapidly to that with wastewater testing. And the wastewater testing was just a part of the response. Most of the response was really on the ground relationship building with the communities in these areas, to understand, to explain how polio spreads, why people that carry or have polio may not have symptoms. And that was a difficult thing, to be able to show that, yes, we have information that shows that polio virus is present and it's communicable, but yet there were no other reported paralytic cases last summer, even though there were probably dozens, if not thousands, of people that were sickened with polio. Right now, we continue to do that. Updating our website with all of that information, and as you can see here, this just shows that although we continue to do so, we have not detected any more poliovirus in these counties this year. So thank you for again having me. Sorry I couldn't be there in person, but glad to stick around for questions at the end.
Thank you so much, Dan. So we'll move right along in the series here. Our final speaker in this session is Colleen Naughton. Dr. Naughton is an assistant professor in the civil and environmental engineering at the University of California, Merced. Her lab co-designed sustainable food, energy, water systems for and with the underserved, with an acronym of FUSE US. Dr. Naughton created the COVID-19 Twitter handle, Global Wastewater Monitoring Dashboard as well. She is a co-lead of the Healthy Central Valley Together project, monitoring wastewater for pathogens in California's Central Valley. Dr. Naughton was an American Association for the Advancement of Science and Technology Policy Fellow, a returned Peace Corps volunteer in Mali, and University of South Florida for both MS and PhD, and Purdue BS alumni in civil engineering. And it's my pleasure to hand it over to her for her talk that will be focusing on health equity and wastewater surveillance.
Thank you so much, Cresten. Hopefully everybody can see the slides and hear me. Let me know otherwise. But very grateful to be here, and thank you for providing this remote option. I have a young daughter, Marion. She's up here dealing with other aspects of poop now in my life and wastewater. So I really appreciate you being equitable and providing a remote option. A lot of times now conferences are going back in person, which is great, but there's still some of us with young children or immunocompromised or people with disabilities that this is an important part, or those that are international, can't get visas, things like that. So today I'll be talking about health equity and wastewater surveillance. I will be focusing more on like kind of the distribution of sites and where we're monitoring than the data sharing. So thank you for Dr. Persad talking about, having it in multiple languages is important, or people that access information differently. So how we share the data is a whole other equitable issue. I'll talk about different scales of equity from California, where I am, rural, United States, global, and some lessons learned. I just wanted to remind us all of like the definition of health equity. We kind of use this term a lot, and there might be other definitions out here. This one's from the HHS, like Healthy People 2030 initiative, and that was kept from the Healthy People 2020 initiative. So the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the health elimination of health and healthcare disparities. And this is a CDC infographic, and I feel wastewater surveillance or wastewater monitoring would kind of fall under measurement aspects, especially since it can be useful in providing health information in places like Merced, where we had delayed sequencing, not as much access to healthcare and to testing. So wastewater surveillance has really been important in filling those data gaps to know if there's an outbreak coming or imminent or a different variant out there. And I use this graphic a lot in my class to talk about environmental justice and the difference between kind of equity, equality, and justice. So sometimes we do need to put more resources in to kind of correcting these past injustices, for, the system that is kind of swayed towards those with more privilege. And so like at our treatment plants that are in more rural or underserved areas, we might have to provide a courier like was discussed in the morning, or some sampling help. It might cost more to have those plants on board, but that information is very useful, needed, and is also equitable and just. And I got asked some of this at the community of practice teaser that I gave about different elements of equity. There's so many out there, and luckily there's some great indices out there. A lot of you familiar with the Social Vulnerability Index from CDC that has 16 different indicators, and not just about race and ethnicity, which is very important, but household characteristics, socioeconomic status, and housing type and transportation. So getting at these different layers of equity from those that are over 65 or under 17 that might be like, more vulnerable to pathogens and to health disparities, as well as poverty and other housing issues. There's also what I used in what we presented last year about like an environmental justice approach towards wastewater-based epidemiology. California has CalEnviroscreen that combines sort of some of these socioeconomic factors with also exposure to other like air and water and waste pollutants. And there's another one US EJ screen, which is has like some similar amount of and diversity of indicators that you can use to help select and prioritize sites that you might be wanting to do for wastewater monitoring. And some that are with a little bit within those indices, but there's just all sorts of other things that you might want to monitor for. And I'm not going to provide you the answer. It's really dependent on your program, your scale, and even now we think like the pathogen that you might be monitoring of what you want your goals to be. The importance is that you discuss them and you decide on them and you publicize and you continually monitor and evaluate if you're meeting those equity considerations. And so in California, I know Alex, you was there, would like to meet you in person one day. I think they wanted 50% at least of California counties represented. Earlier, Pearson talked about states like that. We have every state represented now, which is great in the US, or you could do, we didn't have as many of the US territories represented. I know US Virgin Islands was finally added, but there's still others that are not have access for wastewater monitoring. You might want to do regionally. In California, we looked at differences between the Central Valley, coastal, northern and southern California. So Central Valley was not represented as much in the monitoring, or rural and urban. We had 85% of the sites monitoring in 2021 were urban compared to 15% rural. So we weren't capturing data from more of the rural areas that have more that were more disadvantaged for seeking like healthcare and also impacted by COVID. Indigenous populations, that was great to hear about the Minnesota speaker about being onboarded more of some indigenous or native populations. There's talk of, monitoring for incarcerated or people that are incarcerated may be important since they may not be served by the sewer system or have their own separate sewer system. People experiencing homelessness or the unsheltered. There's been a lot of programs, I think, even in Arizona or in the Western US, and I'm sure other places that have helped prioritize this, or they might be monitoring even in the rivers that some of these encampments are off on. But of course, you want to be careful of how the information is shared and used to not target these populations. You could use healthcare access, that's in some of the indicators, or the disease severity and disparities. So we looked at the map of like cumulative cases per 100,000 and which areas had testing. So luckily, like a lot in Southern California had very high case incidence rates and access to testing, but there were some higher incidence rates in Central Valley that weren't being served by wastewater monitoring. And I'm sure you can drop in the chat or tell me in Q&A or whatnot others that I might have forgotten or not included, not meaning that they're not important. So disease severity and disparities, we know with COVID that it's been detrimental to people of color compared to those that are white for cases, hospitalizations, and deaths, even like almost 2 times or like 2.5 times for American Indian or Alaska Native for hospitalizations, like it's twice as much for Black populations. And so we need to make sure that this testing and the action taken from it can help serve these populations, which wastewater monitoring can do at a city level. It does cover a wider array of people than say testing centers did, or those people had test seeking behavior. And even deaths are also more. I know Cresten said to talk, beyond COVID as well. And so most other pathogens, and even like with opioids, it's disproportionately affecting people of color and other races and ethnicities more than those that are white. So I think flu hospitalization rate is 80% higher for those among Black, and the vaccination rate is lower than the average for Black, Hispanic, and American Indian, Alaska Native. So it's great that we're adding flu monitoring in addition to COVID as well, a lot nationally to get more of this data. And there's recent kind of reports and findings coming out about the decrease in life expectancy, unfortunately, in the US. And this was also along racial ethnic line, not equitable. And the decrease has been larger for people of color. But luckily, there's some good news with wastewater monitoring. As I said, it can help with those populations. And we've seen, and thanks to Alex Yu and others at California Department of Public Health for their great monitoring program and expansion from like 2021 when we did this analysis to 2023, I think from 48 to now 78 sites. And not just Healthy Central Valley together. We do like 8 plants that are covered now within the wastewater scan network that's uses Verily. But you can see the Central Valley is much more represented and more Northern California sites as well. And we did some analysis of the data. We didn't know, like also with like less access to healthcare, like health cases, less access to other health metric and data, how well the wastewater data would correlate with cases and hospitalizations, ICUs. And we lagged this data. There's actually a bit of a kind of early warning or lead time for the wastewater, but lagged it. So you could see that the data, even with less access to this other health metrics, that it did correlate well with other health metrics. And so it's important to have this tool in these communities. We have a lot of great public use cases I can also share from in Q&A that how it's been used and really looked at. There's some other research out there, and apologies if I don't cover it, but one from Holmes or Dr. Holmes in Louisville about using wastewater for health disparities in rural areas. And so there's other ways that you'd monitor more at the facility level, for example, for covering these areas. And this paper makes a great case for more access and need for testing for rural areas. And BioBot had a report. Septic tanks is always a question, and CDC has a great website on monitoring in low resource settings. And because 20% of the population is like, or 1 in 5, I think, of the US households, they say, is served by septic tanks, which isn't being covered by the wastewater monitoring at wastewater treatment plants. But there's some interesting data that even like we thought that maybe those served by septic systems are more likely to have lower incomes, but there are higher income people living in the second homes and even within cities that are on septic and higher income. But it does vary by state. I know Alabama has a lot served by low income resources, but you can still, you could maybe target more testing or other surveillance methods in those communities to have a wider picture coverage. Wastewater doesn't necessarily have to be used to cover all those communities. So I've seen some emerging papers to test septage, which might be interesting, or you could do more of the household, the building level. And also people that use septic systems, they do go to cities and use toilets and other places when they travel or go to work. And so they can still be counted within wastewater surveillance. This is some initial from master's thesis at Loma Linda University analysis of, in the earlier data, we have a bit more equitable coverage now, but from 2022 with the social vulnerability index. So the monitoring was less representative for those in the highest percentile of social vulnerability, 8%. And but we've now, with expansion, I think, of news, have a bit better coverage. And then, as from my initial paper, or the six different territories for the US, I think there's 5 here, didn't have monitoring programs before. So important to kind of look where we're monitoring and how equitably distributed it is at different scales. And I still, even though we're kind of focused on the United States, important for our health, we know the pathogen does not know respect to borders or doesn't check itself at the gate. And it's important to, and Dr. Medema kind of talked about this with the global surveillance network, and like even we'll hear later about monitoring at airports. So this could really help if we preserve some key places and have it more accessible to those in low and middle income countries, as well as underserved areas in the United States. We have advanced. It used to be, I think, 65% of countries were high income, and now it's 57%. So there's more in low and middle income countries, but still a lack of access. And I see the programs that are coming down or taking their dashboards down or not monitoring are more that are in the low and middle income countries. And so we need to, help extend their funding or be able to help them keep monitoring. And I was hoping to have this released by this conference, but it's close, I promise, it's very close. But looking at these key other targets for a global dashboard for flu, RSV, polio, and Mpox, but I can tell you that like the data for these other targets is less representative than COVID, and we'll be doing the analysis for high, low, and middle income countries. And so moving forward, I just asked it, like I have been seeing this somewhat with optimizing sites, that we preserve equity, like even if you're downscaling, just downscale equitably. And that as we expand targets, still think of equity. I mean, COVID, we like really just kind of prioritize the easier plants too. Those, you know, closer had prior monitoring, but we don't really have as much of an excuse now. I know it's like still more difficult to keep them on board, but you know, we do need to keep thinking of equity for other targets. And, you know, for the next emerging pathogen, it's great that we have this network in place and have all these sites and opportunities so that we keep equity at the forefront. And so my lessons learned, I've talked about them, are like kind of discuss, set, and publicize and evaluate your equity targets. I, you know, like to see this as, you know, part of more front and center on News's dashboard for existence, or for example, and also wastewater scans dashboard. And even if you use an index, please still check back with race and ethnicity so it's not underserving different populations. Doing this analysis, academics, we always want more data, but it would be easier to see what populations are served if we had better and more sewershed information. We used local health departments to consult for where to monitor for Healthy Central Valley together. And so that's important and can help you target ones that you wouldn't necessarily. And I thought there was a lot of talk earlier about leveraging universities. It really helped that we, when UC Merced were located in Merced and could more easily go to the treatment plants and encourage them to monitor, and that we, you know, used to have field trips and like those existing partnerships, and that rural and underserved areas might need more support, and we should still support global monitoring in low and middle income countries. So I think I'm getting to time, so I can talk more about like a use case later, but thanks again. And this is a huge collaboration with a lot of different partners, and so I want to acknowledge all the funding sources and partners.
Well, thank you so much, Colleen, and thank you to all four speakers for a very exciting session there. We're discussing where in wastewater is just an exciting time, where we have water reuse on one hand going from toilet to tap. And then I realized through the common theme of all four of the talks that we in the public health realm are moving from toilet to tap. So with that kind of considerations, where it's much more of the public access of data, we now have time set aside for questions. And if there's a question first in the room to kick it off, please feel free to raise your hand and we'll get the mic to you. And we have accumulated quite a few questions online.
Yes, we do have a few. We can
Let's
start with an online question. All right. And I know they're pulling up the speaker videos right now, so you will be able to see them. All right. This is for you, Wydale. They were talking about you in their breakout room, and they had two questions for you. One, is your data on opioids subject to FOIA, even for the smaller sewer sheds with populations fewer than 3,000 people? And then the second question is, how do you work with those in police not to misuse the information to incarcerate or punish?
Thank you. Well, first of all, thanks for the question. So the first question was about FOIA. And so we consider our data open by default. That does not mean there's not exceptions to that. So for example, I always share, we're not going to share an address of an undercover officer, those sorts of things. We do offset on our GIS maps. We offset our EMS opioid probable causes. We do that for a lot of things, domestic violence, things like that, so that we are protecting people at the same time, but also sharing to a level that's acceptable by our community. So we share all of our data in our open data site. You can pull down our Tuesday data and our Thursday data, and then we report the weekly average. So it is subject to FOIA, and we take that very seriously. We would rather have data on our open data site and our dashboards, which we do multiple dashboards, not just with wastewater. We would rather have it there for people before they even have to ask for it. And that is our goal as a data-driven city, is that it's their data, it's our people's data, and it should be out there. And the second part of the question was about,
It was about how do you work with those in police not to misuse the information to incarcerate or punish?
okay. So when we first started this journey with opioids back in 2018, we purposely did not have law enforcement at our table. We had a monthly interdisciplinary meeting. Adam was there every single month. And we made sure that we just didn't have law enforcement present. Now, with still having, we've gone from 2% of our EMS calls related to opioids to about 3%. We're looking at it as far as wastewater surveillance can be one of the data tools. It's not the only data tool that can be utilized by law enforcement. It's public. It's been out there since day one. If a law enforcement agency wanted to utilize the data, it's there. But our regions are so big. We have a threshold of 3,000 people. If you look at our map, we're not getting into neighborhood, cul-de-sac, industry, buildings, those types of things. We're not getting into that level. So there's some limitations that just even the way that we report it and collect it have for law enforcement. We do not collect anything below that 3,000 foot level. So even if I wanted to say, hey, we could break this down in another area, that's just not our practice and our policy now in our program. And I think that's part of kind of planning for what are the ethical dilemmas that can come down the road that we don't even realize today, that we didn't necessarily realize back in 2018, but asking people, talking to people, experts like Colleen, asking, what could we anticipate? So that's, I guess I'll summarize with that, is that we can't even get below 3,000 because we don't even have the sampling capability right now. And we don't pursue that. We're pursuing just so that we have informative areas that are across the whole city. It's everybody, not just one area of the city, back to equity and stigmatization. So.
Question in the room? We have one up front.
Hi, Allison Wheeler from Colorado. My question is also for Wydale. So can you talk a little bit more about your town hall and what that looked like and if you continue to do that?
Thank you. Colorado, great neighbors of Arizona. So our opioid town hall, we wanted a way that we could, first of all, we shared that we were starting this program. And at the town hall is where we debuted the dashboard. Alongside, again, reinforcing that wastewater is just one element of public health in our community, alongside a panel of blue ribbon expert panel, our fire chief, we had service providers for opioid treatment and prevention. We even had our president of our Arizona Interscholastic Athletic Association, because of their opioid protocols, similar to concussion training for athletes. They're also doing training for opioids in regards to when an athlete becomes injured and the pressure that can be on that athlete from their peers to share even prescription medication. So we brought together also people who have lost loved ones to opioid addiction and misuse and abuse. And so we brought together a whole community. This goes back to having multiple stakeholders part of this. So we continue to have these conversations. We recently hosted a town hall at a local school. At the request of the school, we had actually law enforcement actually was the ones requesting at the school. And so wastewater became part of that discussion. So we have an ongoing engagement plan. We can never do enough to engage with our community. And that's why we constantly are doing press releases. Our 311 operators, our one call to City Hall, we give them kind of the FAQs about it. One of the very first questions we got when we stood up our COVID site was, where's my neighborhood? I want to see what's going on. So very similar to the weather analogy, what's going on around me so that I can make the best decisions possible. Thank you.
Should we do one from online?
Online.
All right, this is for you, Dr. Persad. Oops, sorry. Give me one moment. Okay, Dr. Persad, great presentation. How can we involve the public, especially vulnerable populations, in decision making?
Thanks. So a couple of approaches that come to mind from other public health contexts that I think could be promising would be to have some sort of facilitated deliberative process around public display of data. I think often it's tempting to just have, we'll have a meeting where people can come and give comments or something like that. I think that often tends to draw people in who already think they have a pre-existing interest in the question. I think having facilitated deliberation where you intentionally go around to have a representative group of people brought in, almost like a citizens jury, to talk about these questions can be really useful. I think another avenue that I think is probably the most important theme that I would stress is like try to make sure that the feedback and information that you're getting about public display isn't just coming from people who take themselves to be pre-existing stakeholders, but people who might be affected whether or not. So I have colleagues at Michigan, for instance, who have done this with Medi-Cal beneficiaries in California to find their preferences for insurance, and they go out and deliberate with them and find some really valuable results. I would actually, if I'm able to call, I would be really interested in Colleen's thoughts about this as well. I've been thinking about it from the display side, but from the side of sort of citing the monitoring itself, I'm curious about whether public involvement has played a role in sort of equitable citing decisions.
Yeah, I mean, I think I've seen people like I'm sure those at the health departments or even utilities get contacted like sometimes like, well, is this being done in our area? Can this be done? At least on Twitter or now X, people are calling for their sites to be monitored. So they may have news or people at CDC may have more to say, but that may have played a role in increasing some of the access. I'm not sure about so much like a formal process for the public to be involved in citing other than at Arizona, but it's a good question. But I think there's been at least public pressure.
Excellent. Thank you so much. Do we have any more questions in the room? We have one over in the center. And one more online that we'll get through.
Hello, my name is Matthew Burns from the Health Department in Idaho. First off, thanks for the ethics talk. It's been a lot of conversation for our state and our health department, so it's been helpful here. My question relates to the Tempe data because drugs is what everybody's kind of talking about right now, but I would welcome responses from the rest of the panel. One of the things that has come up is the concept of data-driven redlining, in which specific communities are discriminated against because of you could point to a community and say, look at all the opioid data, therefore loan rates go up or insurance rates go up, or all of the other impactful policies that can happen to not just an individual, but to a whole 3,000 or less person community. Are you looking at what kind of data markers would tell you if that's going on in response to your dashboard? Or does the panel have any thoughts on what to look for to ask if that's happening as a result of the wastewater surveillance that we're doing?
I'll jump right in. So I appreciate that element, and it's a large piece when it comes to ethics, because I also look at it from what are the negative economic impacts, in regards to how we district collection areas. We found actually the opposite to be true, that we have had a lot of economic interest in Tempe because we're being innovated. We are looking at our public health, which means a workforce, a student population, as well as, just our general population. So we've actually gotten a great response in regards to that. But I don't know if we'll be able to tell that immediately in regards to, the elements such as higher insurance rates. We know that if you're in an area that has higher vehicle accidents, your insurance goes up. If you don't have great fire protection programs, your insurance goes up. So it is on our radar in regards to how do we look at that and how do we anticipate what we do about that. On the flip side, we've actually had the benefit of wastewater being able to share with our community that this is happening in our community, and it's a community response and collective action. So it's not been something that our community has been able to just deny and say, it's happening there, or it's only with students. We've actually, by the way, when we track not only wastewater, but the other complementary data that goes alongside with it tells the broader picture. But I really love that question because that's something that we're kind of always exploring right now, trying to figure out what will this do. So, and do no harm always being first mantra, right?
Do you want me to go ahead and ask the last online?
I think so.
All right, this one's for you, Dan. Did the wastewater surveillance work in polio help improve vaccination uptake in young children in the impacted communities?
Yeah, I'm not sure whether it was the wastewater data per se, or it was the paralytic case. It would be very hard for us to be able to distinguish, the fact that there was wastewater in, or there was poliovirus in the wastewater versus the, I guess the announcement and then the follow-up public health work done to try to avoid having any more paralytic cases. I think on the flip side, what we saw is, although wastewater continued to show poliovirus in the area, the uptick of vaccination did not follow that. The uptick of vaccination did follow the announcement of the paralytic case. So we do have an interesting dilemma there as wastewater epidemiologists, all of us on this call, is our information understandable to the public? Are they getting this information, and are they as aware as we are of what that means? Especially in certain communities, right? So there's the I guess the inequitable uptick of information. We all are well educated and have access to a lot of resources to understand what this data is and what it looks like, and when it goes up, what does that mean? When it goes down, what does that mean? That's not all well understood by the general public. So I think we have a long way to go in this field to be able to prove and to use this information to get out to the public in an understandable way. And again, I think this also means even more so that we need to integrate wastewater data with syndromic surveillance and other surveillance tools. We know we can detect it in wastewater, flu, RSV, Mpox, but are we matching it up to cases? Are we matching it up to people's lives? And that's really what the next generation of wastewater surveillance should be focused on.
Well, thank you so much. And I would like to extend my gratitude and thanks to Wydale, to Govind, to Colleen, and to Dan once more. And if we just give them a round of applause.
Thanks, Cresten.
And also, I'd like to extend my thanks to all of you for giving also a bonus 4 minutes to this discussion here, because it's eating into your break. So there is a break now, and we will reconvene at 3:30 p.m. in Chicago time here. And that will be for the hot topic session. So do come back, because it'll be very hot, it seems. So.
Thanks, Cresten.